Right, welcome everyone. I hope you've enjoyed your breakfast and yesterday evening. I thought it was a fabulous start to the meeting yesterday. Some really heartfelt and really memorable talks yesterday to introduce the sessions. And I hope that this morning will live up to the same expectations, although maybe not pluck as many heartstrings. So unfortunately, you're seeing me here because Judy Garber is unfortunately indisposed. She's not going to be able to come here or to ASCO because her father is very ill at the moment. So she sends her apologies. So we will have a potential gap in the program. I'm not intending to fill that gap, but obviously it does give us some leeway if things get a bit stretched later on. So I'm going to start the session, and then Patricia is going to talk about the interesting phenotypes of the common p53 mutations in Brazil, and then we're going to have some other talks. So I'm going to focus really on my sort of particular area of interest in LFS, which is the breast cancer phenotype, but also talk to you a little bit about the work that we've been doing with whole body MRI, following on from the Great Toronto Protocol, and tell you a little bit about our experience with that. So, without further ado, this is just an introductory slide in terms of our experience, that when we use the classical Li-Fraumeni syndrome criteria, which includes obviously a sarcoma under the age of 45, and two other tumors, including at least one classical LFS tumor under 45, we get a pretty high detection rate in p53. And importantly, you need to employ an analysis that looks for whole exons being deleted out of the gene, not just sequencing, as 10% of genetic faults in p53 in the germline are actually MLPA deletions. And with that, we're getting up to about 83%. And I think it's really doubtful that there is another real Li-Fraumeni syndrome gene. There may be one out there, but I'm pretty doubtful. I think many of the remaining families might be explained by moderate risk genes plus SNPs plus chance, rather than there being another really significant LFS gene. Obviously, Chompré criteria are more sensitive at detecting p53 mutations. We heard yesterday about the misconception that de novo cases were rare, and that's because obviously people have applied Li-Fraumeni criteria, which means you have to have a family history. Once you go into the sporadic settings, particularly childhood choroid plexus carcinoma, rhabdomyosarcoma, you find really quite a high de novo mutation rate. And I think at least 40% of TP53 mutations are going in the end to turn out to be de novo. So you have this large gene here, or large-ish gene, and I know that Thierry Freiburg is going to talk about the importance of where the mutation is in the gene and whether it's a dominant negative mutation. And it's important for the breast cancer story that we take that into account, because although the mutations, the dominant negative mutations in this part of the gene, the middle part of the gene called the DNA core binding domain, are the ones that have this very high risk and also high risk of breast cancer, mutations that are not typical outside that domain, that are not missense mutations, actually may have just a breast cancer only phenotype. And now that we're doing panel tests, and you're going to hear a little bit more about, or you were going to hear about that from Judy, but now that panel tests are being carried out, we are finding more and more p53 mutations in breast cancer families that we weren't seeing before, because in the early days it was quickly written off that you didn't get familial breast cancer alone with p53. Okay, so let's move on. So in terms of, that's just a summary of what I've just said. You can see here this very high risk if you have a typical missense mutation in the core binding domain, and really high risks of malignancy, particularly in women because of the breast cancer difference. And that's sort of shown on this chart. I don't think anyone can really come up with an unbiased estimate of penetrance because LFS families are so typically small. And once you take out the index case who often has breast cancer, it doesn't leave you much in the rest of the family to look at an unbiased ascertainment. I guess one of the benefits of having the Life Consortium is maybe we can join all our families together and try and come up with a less biased assessment. But what I'll show you is the best that we can. And you can see here that P53 really is the strongest breast cancer gene ahead of BRCA1 and BRCA2. The risks of breast cancer are higher by the age of 50 with a P53 mutation. So one of the early places I started, and I worked with someone called Jill Birch, who many of you may know, came up with a Birch criteria. She was one of the first to really nail down the link between breast cancer and sarcoma on an epidemiological basis. And so we did have quite a good thing going in Manchester in terms of epidemiology and looking at that. So in the very early 90s, I set out to try and nail down the inherited component of breast cancer at a very young age 30 years and under. And I looked at our population in Greater Manchester, about 4 million people. We had a cancer registry that had been going since 1960, and that allowed me to identify cases, both retrospective, before 1990 when I started, and semi-prospectively up to 1997. And when we looked at that, in 1997, there were only 139, about half of the women were still living. And we did manage to get quite a few DNA samples, luckily from some of the women who unfortunately then went on to die. So originally there were 166 women living, and we managed to get DNA samples out of 120 of those, so a very high pickup rate. But interestingly, even those, particularly those where the consultant originally refused to contact the woman concerned, many of those have come forward since because of further concerns in their family or the fact that they realized that very young onset breast cancer does have a chance of being inherited. So we have got a reasonable sized sample set. Now we started off with fairly old-fashioned testing. This has now been updated, and we have done pretty much all of these samples now by full sequencing of BRCA1 and BRCA2 and MLPA, and the same in P53. So we do have 122 samples on that group. 70 of those are sporadic, and in that sense there was no suggestion of anything to do with Li-Fraumeni syndrome in terms of tumors. There was no breast or ovarian cancer in the families. And the rest, you can see here that there were 3 Li-Fraumeni syndrome, 3 Li-Fraumeni-like families, and also 46 familial breast ovarian cancer families. And this is, again, just a summary of what we did. And the pickup rates you can see here, 22 BRCA1 mutations, 9 BRCA2 mutations, and 7 in P53, which comes out at around 5.5% for P53 mutations in a population-based sample with really very little bias there, except potentially the main bias is those that had died. So if you have a more aggressive disease, perhaps some of the BRCA1s may have passed away, then you may be less likely to find mutations in that group. But importantly, of the sporadic cases, 6 out of 70, 2 of those had P53 mutations. So P53 was more common in the sporadic cases than BRCA2. So these are the sporadic cases here. 4 had changes in BRCA1. 3 of those were deleterious, including someone who went on to develop bilateral disease at a very young age. And 1 was a variant. There was 1 definite mutation in BRCA2 and the other was a variant, and then 2 definite mutations in P53. That changes quite a lot in the familial set. This is familial breast and ovarian cancer in the family. And you can see here that we actually picked up a lot of mutations, 19 pathogenic mutations in BRCA1 and 8 in BRCA2, but none in P53. And this again was another reason why we stopped looking in familial breast cancer, because the initial pickup wasn't there. So in the Li-Fraumeni and Li-Fraumeni-like group, we found 3 P53 mutations out of 6, and actually 1 BRCA2 mutation in a family that had a very early onset glioma as well as breast cancer. And that's one of our P53 families that was Li-Fraumeni-like. This is a 29-year-old with breast cancer. Her sister developed breast cancer just over the age of 30 and also had an aggressive astrocytoma. And the father, who was the parent in common who must have carried the mutation, had an early onset pancreatic cancer. Not a typical spectrum tumor, but almost certainly related. So when we sort of move that on to an increased data set, now this now is more biased towards the familial setting, because these are people who primarily have been tested for BRCA1 and 2, and also the sporadics will tend to enrich for high-grade triple negative because of the link with BRCA1. Then you can see here that there's really a very high pickup rate in this group, 43 BRCA1, 26 BRCA2, and 13 of those that we've tested. So still 6% of those under 30 and under samples have P53 mutations. And the typical thing that we're seeing in this group are high-grade triple-positive breast cancer, so HER2 positive, so Herceptin treatable, but also a lot of high-grade comedo-DCIS. Now, that's pre-cancer in the sense that it isn't yet invasive. And that opens up a real opportunity. If a lot of P53 goes through high-grade comedo-DCIS before it becomes invasive, then these can be picked up before they're cancer, before they're invasive on MRI scans, and that really is a very helpful thing, that someone may not have to go through chemotherapy because they have a pre-invasive malignancy. So here you can see the pickup rate in 8 out of 102 sporadic, and half of those actually had P53 mutations. So P53 was actually more common now than BRCA1 and BRCA2 separately, and as common in sporadic cases as both put together. So in terms of the breakdown, there are 4 out of 88 sporadics that we've looked at. So we had looked at a few less sporadics in P53. Only 3 out of 120 hereditary breast ovarian cancer families. There were, in total, 25 in our entire cohort that have developed breast cancer aged 30 or under with P53 mutations. I've excluded those that weren't the index case that we tested. So if we include those, then it goes up very close to the French detection rate of around 14% when we add all of those into the mix. And this is a paper written a few years ago that was the first to really point out this very strong link with HER2-positive breast cancer. Most of the original set that was between Southampton and Manchester turned out to have HER2-positive, triple-positive breast cancer. And these were the first clue, really, that we were seeing something different in these breast cancer families. So these are mutations outside the core binding domain in exons 9 and 10, not typical mutations. They're splicing mutations and a nonsense mutation that were not causing typical Li-Fraumeni syndrome. And this is one of these families. This family here, there's a young girl at 29 who developed breast cancer and then got breast cancer on the other side at 38, sister at 41, and a paternal grandmother developed breast cancer at the age of 31. The father had prostate cancer. This looks to all purpose a BRCA2 family. It is not a BRCA2 family, it's a P53 family with this mutation outside the core binding domain. We now have 4 such families that look exactly like BRCA2 families that are P53 families. And if you put them in BRCA-PRO or Boadicea, you come up with 97, 98, 99% it's BRCA. Because those algorithms do not take into account that P53 can contribute to these very, very high-risk breast cancer, apparently breast cancer-only families. But a warning here, this lady here I'm going to talk about later on, because we found something on her whole body MRI scan, and so this family now isn't just a breast cancer-only family. So when we look at the contralateral incidence in the entire cohort, you can see here this incidence about 0.5% per year, which is typical of what you see. So by 10 years, about 5%, by 20 years, about 10% of women have had breast cancer. When you look at by mutation type, here is P53, very high rate of contralateral tumors, but based on relatively few people who've been diagnosed under 30. As you can see here, this is Thierry's paper. I'm not sure that he's going to be talking about this, but this 6% figure is very typical between their very large set of under 30 cases, or 30 and under cases, and ours. So I think it really is becoming clear that it's at least that sort of figure in women diagnosed under 30, and that will be higher if they have high-grade DCIS, comedo-DCIS, or HER2-positive breast cancer. So in terms of, gosh, have I lost? Right, in terms of the under 30 element of this, really that's the main take-home message, this sort of around 6% figure, and it is in the sporadics as well. This is our best estimate of the cumulative onset, so about a 70% risk by the age of 50, considerably higher than in BRCA1 and 2, but I do give the proviso that it's almost impossible to come up with an unbiased assessment. So this may still be an overestimate of the risk, particularly with mutations, some unusual mutations like the Brazilian mutation. We have a family that has 5 women over the age of 50, none of whom have breast cancer. So that's saying that there are probably some mutations that do not give the typical phenotype, including breast cancer. So this is just to show in our largest set of P53 families that the contralateral risk, you can see here about 2 to 2.5% risk in BRCA1 and BRCA2. So by 20 years of follow-up, between 40 and 50% of women have had breast cancer in the other breast if they have a BRCA1 or 2 mutation. Very little difference between the genes, but significantly higher contralateral rates in P53, up to 70, 75%. And so it is something we really have to discuss the contralateral risk and what to do about it in someone with a P53 mutation. So, in terms of the incidence, we did publish this some years ago, and I think you saw this figure yesterday. We published that 1 in 5,000 women may have a germline P53 mutation based on our population-based testing in breast cancer. And that figure, I think, is maybe going to come true with a panel testing when we're putting out testing to more people out there in the general population, not just those with a family history. And again, it's because of the bias to thinking it's only Li-Fraumeni syndrome if there's Li-Fraumeni in the family, just ignores that de novo mutation rate, which may even be higher than 40%. So in terms of screening, until recently, there was no consensus on what to do. I think we're all pretty much moving towards, if not totally embracing the Toronto protocol, and we certainly are using whole body MRI. And I think there's absolutely no doubt we should be using breast MRI, and that has to be an additional screen because you have to go into a scanner on your tummy with a breast coil wrapped around your breast, and you have to have gadolinium enhancement. We need to be picking up these tumors extremely small, and you have to have bespoke screening for breast cancer on top of the annual whole body MRI scan. So this is obviously the original description of the Toronto Protocol published in Lancet Oncology in 2011, although we heard a lot about it from David before that, and that's why we were already starting to develop protocols ourselves for whole body MRI. And in terms of this, we've teamed up with Ros Eales' team at Royal Marsden to do a study which we call Signify, which uses 1 centimeter cuts. So we're trying not to pick up tiny, tiny things, otherwise we're going to end up doing radiological investigations that turn out not to be anything. And that means exposing people to unnecessary examinations and potentially radiation exposure, which we don't want to do. So we've done 30 people have been through our protocol with p53 mutations, and so far there have been 3 malignancies which I'll describe as part of the whole Signify protocol. In terms of the MARIB study, which was our MRI screening study, there were 2 women picked up with breast cancer, both at 29 and 33. They were both high-grade comedo DCIS. So those women were cured of their breast cancer by having MRI screening. Both of them went for bilateral mastectomy, so almost certainly they're never going to get breast cancer again, and they're cured because they were picked up very, very early before it was invasive. So what is the Signify study doing? Well, we're trying to look at the incidence of malignancies picked up, also the false positive rate, how many lesions are we investigating, and also looking at the psychological impact. And because we want to get an idea of the specificity of the test and how this compares to the general population, we are looking at 44 age-matched controls from the general population with no particular family history of malignancy. And already we're seeing that there is an increased frequency of benign, funny things in p53 mutation carriers. Maybe some of those are precursors, and maybe they aren't. But certainly we are seeing lumpy, bumpy things in p53 which are not necessarily malignancy. So this is the protocol. I'm not going to go into great detail, but suffice it to say, they get an MRI, a whole body MRI scan. If we pick something up, we investigate it further, preferably by non-radiological, non-X-ray means, but sometimes we can't really look at it any other way. It might mean a dedicated gadolinium-enhanced MRI scan. And so in terms of the results, there are 75 recruits so far, 67 scans have been done, 49 incidental findings, and these have mainly been in the p53 group, in 30 participants. 15 participants required further scans, 4 with radiation, unfortunately. So far there have been 5 malignancies, one of which, an acute lymphoblastic leukemia, obviously wasn't picked up on this protocol, although it may have been picked up on the full Toronto protocol. And there are some lessons here. 2 of the cancers, 2 of the malignancies were definitely picked up early, and 2 we should have picked them up even earlier. So this is a fairly obvious one. It looks as though, well, how could you miss that? That's a glioma that's been picked up. Here's the whole body MRI without enhancement, you can see here, and here's the enhancement. And there were also in this person kidney and liver angiomyolipomas. So this is what I'm talking about, potentially these other things, non-malignant, that we're picking up in these p53 carriers. And the question is, are these potentially precursors for liposarcomas or rhabdomyosarcomas? Are these potentially a problem later on? We certainly need to keep an eye on them. And this is one of the things that we had to get our eyes in for, this was an osteosarcoma that actually presented initially as a bone cyst and required further investigations before we found there was a solid component. So the sarcoma was sort of tickling up a cyst in the bone. And a similar story here in a woman who had a pericardial cyst here. Pericardial cysts are quite common on whole body MRI. And initially our radiologist, who's really amazing, thought, well, this is just a pericardial cyst. Why do we need to worry about it? And it expanded on the second scan. And further investigation with gadolinium enhancement showed there was a mediastinal sarcoma that was tickling up the cyst. So these are things that maybe we just have to be a little bit more careful not to ignore things, because in P53 they might be the precursors, they might be telling us something that is going on. And this was actually quite a nice pickup. Was a 2.5 centimeter fibrosarcoma, myxosarcoma, that was picked up in the abdominal wall in someone. So she's almost certainly completely cured. Very, very small sarcoma, stage 1. And so really, this is a very early look. It's nothing like what Toronto have found so far, but it does show that there is some potential usefulness of whole body MRI. And maybe the question is, do not ignore the funnies in P53, because they might be telling you something, and they may almost certainly need further investigation with more dedicated MRI with gadolinium enhancement. So the summary of this talk is that obviously P53 is a relatively common cause of breast cancer under 30. Don't ignore a tumor because it's sporadic, and certainly any high-grade comedo DCIS or HER2-positive breast cancer under 30, you should at least ask the question, is this P53? Breast MRI is probably extremely effective, although still there are small numbers in most studies, and whole-body MRI looks to be a useful tool to add into the armamentarium, as the Toronto group have already shown us. So I couldn't do any of this without a big team, and here in particular, Rick Whitehouse, who's done a lot of the MRI work, Tony Howell in the clinic, and the lab people, again, without whom I wouldn't really present anything here. Thank you very much. Would anyone like to ask me any questions? If you want to ask questions, you want to go up to a mic and say who you are, and then ask away. Unless anyone wants to move a mic around. But,
Hi, I'm Elizabeth. I was wondering, you had mentioned about the contralateral instance in breast cancer. Is there any indication that the second tumor tends to be that high-grade DCIS as well, or does it tend to come back as like something nastier?
No, the second tumor is as likely to be a DCIS as it is for the first tumor. In fact, more likely, because often the first tumor there isn't surveillance, the second tumor there is surveillance. So a lot of our second tumors are DCIS. So again, it doesn't mean you have to have a bilateral mastectomy. Maybe you can rely on the MRI, but, do you want to risk having chemotherapy? It's still highly likely if it's invasive, because they're high-grade tumors, it will mean Herceptin, it probably will mean chemotherapy. So women with P53 mutations have to be offered the choice of bilateral mastectomy, and that, I guess, has less worry because they're not worrying about what's going to be picked up on the next MRI scan.
Thank you.
No more questions? You're all asleep? It's too early in the morning? Okay, well, we're fine because we're 20 minutes ahead of schedule. So Patricia, it's you next, isn't it? Yeah? So Patricia is going to talk to you about the fascinating P53 story in Brazil with this very common 337H mutation, and the floor is hers.